recorded.
Well, thank you all for participating in this webinar session, which is the fifth from the Integrated Care for Kids March National Resource Network, and we are going to focus specifically in this webinar on equity, adolescence, and health transformation. And I'm Charlie Bruner, and I will be doing the introducing of our commentators and also providing the overview of both InCK and the work that we're doing. And I'm very excited about the event and the people that we have participating. I will introduce the three commentators who my introductory remarks are really just a kind of a lead-in and setting the stage for them to provide their perspectives on what we can do to achieve equity in our responses within healthcare to the adolescent population. And I think we always try to get speakers, and we are very delighted to get speakers who are leaders in the field and who have been making good trouble for decades on behalf of youth and the communities that in which youth reside. The first presenter, and I will speak to them now, and then I won't introduce them later, and we'll just go through their commentaries, is Margaret McManus, who is the president and co-founder of the National Alliance to Advance Adolescent Health, and she's also the co-director of the GOT Transition Center for Healthcare Transition Improvement. The National Alliance really is a teenager. It was founded in 2006 with the mission to achieve long-term systemic improvements in comprehensive health care and insurance coverage for adolescents. And Ms. McManus has directed, in addition to doing this, she's directed numerous federal, state, and private foundation projects on child and adolescent health. And for more than 2 decades, she has served as consultant to the American Academy of Pediatrics Committee on Healthcare Financing, and is nationally recognized for her expertise on Medicaid and EPSCT. Angela Davis is a doctor and director of the Mount Sinai Adolescent Health Center, which provides high-quality, comprehensive, integrated, interdisciplinary primary care, sexual and reproductive health, mental health, dental, and health education services. Under her leadership, the Mount Sinai Adolescent Center has become the largest adolescent-specific health center in the United States, now serving more than 12,000 vulnerable and disadvantaged youth each year. Dr. Diaz is the Gene C. and James W. Crystal Professor in Adolescent Health at the Icahn School of Medicine at Mount Sinai, and among her honors and recognitions, she is a member of the National Academy of Sciences and Medicine and has been a White House Fellow and was part of the NASM work to write the seminal report, The Promise of Adolescence. And finally, Renee McConey is the Managing Director of Health Services at The Door. The Door's mission in Brooklyn is to empower young people to reach their potential by providing comprehensive youth development services in a diverse and caring environment. Since 1972, the Doors helped a diverse and rapidly growing population of disconnected youth in New York City gain the tools they need to become successful in school, work, and life. Renee helped position the Doors as a federally qualified health center, in addition to being an adolescent center overall and securing its position in today's health system. Her previous positions include roles as regional director of a Planned Parenthood affiliate in the Rocky Mountains and vice president of medical services at Planned Parenthood of Central and Northern New Jersey. We really have people who are both at the policy and thinking level and at the on-ground youth-serving level who are really leaders in the field, and will be providing their commentary after my opening overview of the topic. InCK was established 2 years ago, and its mission is to support leaders in the field to advance child and youth healthcare transformation, which includes producing and disseminating state-of-the-field evidence and resources, and identifying, drawing from, and sharing resources from other leaders in the field to advance all aspects of child healthcare transformation. We have over 35 national partners, all of whom are working on different aspects of making our child healthcare system more responsive to the needs of families and to improve child and family health. This is the 5th webinar in a series, and we provided ones on providing overall framework, practice transformation, then on COVID-19, and then on equity transformation and early childhood systems building. And each is available, slides, recordings, and working papers at our website, and so will this one, which, as I said, has the specific focus on adolescent health. Adolescent healthcare. And I really do invite you, when you have questions or want to make comments, to put those in the chat box, and we're going to leave, hopefully, good time for being able to ask our commentators to respond and to speak more about the work they're doing and the opportunities for the field. I also want to thank, in developing this, we drew upon 3 of our national resource partners, Peggy's National Alliance for Adolescent Health, the Center for the Study of Social Policy, and Susan Notkin, and her work with Youth Thrive and the Prevention Institute, and Rachel Davis, and her work really to set this up, and they have a great deal of expertise and are worth drawing upon in more detailed questions about how to respond through the health system and beyond to engage, respond to, and empower youth, and to help build communities through adolescent health. So I really want to thank them. And I also want to thank Kay Johnson, who also did yeoman work on this webinar and its preparation, and who serves as the chair of our national advisory team. So I really do want to acknowledge a lot of people who went into this effort. The InCK's model and what we have been promoting is a vision of child healthcare transformation that involves practice transformation and really moving from a medical care system to a system that looks at the whole child and provides child and family-centered medical homes with primary benefit promotive services that partner with children, youth, and families and are embedded in the communities they serve. And with that practice transformation also needs to be metrics transformation, finance transformation, and culture transformation, which really speaks to the issues of how we build systems that respond to the whole child and family and have a very strong equity perspective. So that is the overall framing for the work that we have been doing, and it really does build upon the definition of child health, which is really much broader than medical care or the treatment of illness or infirmity. Child health is really a state of physical, mental, intellectual, social, and emotional well-being. And healthy children live in families, environments, and communities that provide them the opportunity to reach their fullest potential. And health equity really is about ensuring that health systems respond in ways that rectify inequities and treat all families with respect and seek to alleviate socioeconomic disadvantage and historical injustice. And really, in a nutshell, the basics of transformation is that it does represent a fundamental change in the overall goals and structures of the healthcare system from a medical care system to a healthy development or healthcare system. And the undergirding practice principles for this transformation are that it is holistic, that it responds to the whole child, not just the medical or biomedical and physical needs of the child, that it is relational, that it starts where the child and family are and connects, engages, and builds relationships with them, that it's ecological, that it responds in the context of the child's family, home, neighborhood, and community, that it's developmentally relevant and appropriate to the age of the child and the developmental stage of the child, and that it's equity-based and responds in a way that is both culturally and linguistically responsive, and that counters any biases that exist and works for equitable responses, both within its own system and larger society. And I really want to note that we have done a lot of research looking at evidence-based programs in the field, and there are many evidence-based programs that are achieving improved results from working with families, but all of the program models really, to a large degree, emphasize these 5 components in their work. And I do want to underscore that it really is, and our work is, about equity. And the Martin Luther King quote of all forms of inequality, injustice in healthcare is the most shocking and inhumane is something we take to heart. And in terms of youth, and I think it's fitting to offer a quote from John Lewis on today, when we really are honoring and acknowledging him, is his quote: "When I try to tell young people is that if you come together with a mission and it's grounded with love and a sense of community, you can make the impossible possible." And I think that when we hear from our 3 commentators and the work that they've done both at a policy level and really on a frontline level, it really is about engaging youth in the way that John Lewis talks about. So now I am just going to go through a few slides around the issues of transformation and why it's so important with respect to youth in our society and the focus on youth. We've done a lot of work, and we placed a lot of emphasis in our other webinars on young children, but the same principles that apply for young children apply to youth, but they are really played out differently. And we do know that too many youth do not have access to services and communities that really are needed to ensure their optimal health and well-being over the lifespan. 1 in 5 currently live in poverty or in communities with concentrated disadvantage. 1 in 4 currently experience significant long-range health or developmental issues due to either biomedical conditions, family challenges, schooling issues, or community context. 2 in 5 are covered by Medicaid and CHIP, and therefore the public systems have a particular responsibility to work with these youth. And we know that profound inequities exist by race, place, and socioeconomic status, that youth of color are more likely to be poor on Medicaid, face environmental hazards, live in disinvested communities, and have the added burden of racism, and they are disproportionately overrepresented in many of our systems. And only 1/3 of children of color really are in families with income levels that one might consider middle class, compared with 2/3 of the white population. So the child health transformation that we envisage is essential to, and it's not the whole solution, but it is essential if we're really going to make headway in achieving equity for all children and youth. And as I said, what we've found in terms of our equity and transformed practices in healthcare, they are distinguished because they do value, respect, and acknowledge the culture, language, and ethnicity of the children, youth, and families they serve. They provide opportunities for engagement and leadership of youth. They really are learning communities around inclusion, diversity, and equity. And they build medical home teams and offices that reflect the racial ethnic composition of the populations they serve, and that they really use their spheres of influence to advocate for equity and eliminate inequities across their communities and other service systems. But as we look at it, and I think that our prior webinars often focused on young children, this one focuses on the distinct opportunity for advancing health and equity with adolescents. And I'm going to be very brief in summarizing what we know about them. And I think our speakers are going to highlight different points in terms of their experiences and expertise. But we know that the adolescent brain development, neuroplasticity, play a special role as far as what we can and need to do as we respond to the adolescent years. We know environmental context and relationships with the outside world are critically important. And want to move forward and really looking at adolescence and the difference between adolescents and young children in terms of both have to be holistic and relational. But for young children, that means it's inextricably linked to really the parent-family health. In adolescence, it's linked to the use, view of, and relationships with others and the neighborhood, and not just the family. Ecologically, it's for young kids, it's primarily in the home and with the parents. With the adolescents, it's at school with their friends and peers, alone and at home. And developmentally relevant in the early years, it's about early attachment and self-regulation, while developmentally in the adolescent years from 12 to 24, it's really about executive function, decision-making, sexuality, and managing risk-taking. One of the seminal publications on adolescence is the National Academy of Science, Engineering, and Medicine, The Promise of Adolescence, which was put out in 2019. And Angela Diaz was one of the members of that group. And really, it does talk about why adolescence is so important and what the promise is there, and emphasize that adolescents' brains are neither simply advanced child brains nor are they immature adult brains. They're specially tailored to meet the needs of that stage of life. And biology, population, and stress all play a real role in how those adolescent brains do develop. During that period, in early adolescence in particular, there's a heightened sense of reward, willingness to take risks, and the salience of social status and connections with others. And in later adolescence, and the prefrontal cortex is not really fully mature until 24, really advances as children experience that greater sensitivity, reward, and heightened willingness to take a risk, the impulse control, decision-making, and empathy. And it includes response within the home, but also with the wider net of social relationships. And so youth is that period of time when social relations and experiences affect development, and that's when youth are really learning their new roles, cultural identity, self-identity, sexuality, resiliency, empathy, reciprocity. But where absent, adverse community environments can provide huge threats to their adolescent development. And we also know that health has a significant role to play, and health practitioners have a significant role to play during this period, and that they, in fact, have things that they do want and can benefit from in their interactions with health providers, that adolescents want to be engaged in conversations, not lectures, their privacy and confidentiality respected, be accepted, and be treated with respect, confidence, and professionalism, and offered a trusted relationship with their providers. And I think in addition to having really two of the flagship adolescent health programs and systems here today to speak about that, they really do model that trusting relationship and ability to make those connections with adolescents and to reach them where they are. And as a result, we do have primary practice and program models, ones that are preventive, promotive, and developmental in terms of providing adolescent health care. And we have those mapped out in terms of what happens and should happen in office visits and medical homes that the American Academy of Pediatrics has set forth as guidelines and bright futures. We have a lot of evidence-based, school-based, and community-based clinics and youth services programs that have achieved health gains, and both in terms of medical health and in terms of social, emotional, cognitive, and relational health. We have health practitioners who have worked to develop peer support youth groups that focus upon belonging, reciprocity, healing, and recovery that have shown great impacts on responding to particularly youth who are very vulnerable and who may have had experiences in earlier life that make their pathways problematic. And we have many adolescent-focused mental health, responsible sexuality, and substance abuse services that also have proved effective. So we have a legion, I think, of programs and practices. And again, the Promise of Adolescence highlights many of these, and they are in other studies and reports. They really are reflected in what we know we can do and what child adolescent health practice can be. And we know that it's more than just a program model. It is around trust, parents still matter, youth, reciprocity builds resilience, a caring adult makes a difference, that we really speak to issues around medical health, responsible sexuality, and limiting risky behaviors from the way youth talk and think about those, and not just from a medical, clinical, or moralistic perspective. And that practitioners in the health field often really can be that bridge and that link for youth with other systems that they are engaged in, and sometimes are not always as friendly to them as they could be, and that practitioners often have to be nimble in meeting youth where they are, which means sometimes in the practitioner's office, but maybe extending beyond that. So I just want to conclude, and I know I went through a lot of background material, but it really is that we do know enough to act. We have from us the science of adolescent development. We know that this is a time that's very important. It's a time of malleability of youth that we can make great change and create opportunities. We know the harmful effect of inequity, racism, and other isms on youth and well-being. We have exemplary evidence-based practices in the field, and we know that healthcare can play a role. We further know that it really is about the principles and attributes of the exemplary practices. And we know that we don't right now, we have this exemplary practice, but that's not where adolescent healthcare as a whole is today, so that we do have a challenge and an opportunity to transform adolescent health. And really that we do know have enough to act, and we certainly have enough to act when we can build upon leadership and the people who've made good trouble for decades and really learned as they've gone along in designing, implementing, and operating adolescent health services that really do put adolescents at the front of this work. And so, again, I want to remind you that you can put in questions in the chat box, and we're now going to go to the commentaries from our three presenters. So I'm going to turn it over to Peggy McManus.
Thank you very much, Charlie, and thank you for laying that groundwork. I wanted to just take a few minutes to talk about the role of Medicaid in advancing adolescent preventive care during this pandemic period. So if we could move to the next slide. So briefly, in good times, the adolescent well care visit rate for Medicaid insured and CHIP insured youth is below 50%. And you can see there from a high of 70% in Rhode Island to a distressingly low 18% in Mississippi. And we did a series of interviews with state Medicaid leaders that scored the highest on adolescent well visit rates. And what they said were the key factors were the alignment of payment incentives with adolescent well visit performance. They also highlighted the importance of their periodicity schedule with the AAP's Bright Futures guidelines, the links with state Title V public health performance efforts on adolescent well visits, and specific quality or performance improvement initiatives that were really designed to address improving access to well visits, as well as the content when the teen came into for the well visit. If we could go to the next slide, please. So in the notion of having 3 slides to present today, I think it's really important that during this COVID time that state Medicaid agencies and their MCOs update their outreach and informing strategies to ensure that youth and families know where they can access care, especially those who receive very convenient access to school-based health centers and school-based mental health programs. Many of us are very concerned during these times with the loss of that easy access. The second suggestion would be that the EPSDT should prioritize assessments of social determinants and behavioral health risk with referral resources at the ready. We know that gift cards have been shown to be effective in helping increase adolescents' use of care, so encourage that as well. Medicaid has the opportunity to use more regular than annual preventive visits, so I think it's really important that the interperiodic visits are encouraged so that youth could have additional preventive visits to address mental health or other concerning symptoms. And finally, I think that there's a great need to partner with youth, adolescent providers, schools, and community-based organizations to help youth and parents reconnect to medical, behavioral, and sexual health care during these difficult times. So I'll stop here and look forward to hearing from my colleagues from New York. Thank you.
Thank you, Peggy.
Thank you, Charlie. You want me to go?
I want you to go, Angela.
Okay. So good afternoon, everyone. I want to start by just giving a few highlights of the Promise of Adolescence report, which highlights that a tremendous brain maturation during adolescence, leading to both adaptability, plasticity, and heterogeneity, allows adolescents to explore new environments, learn and adapt to changes, build new relationships, learn how to make decisions, and take responsibility for their lives. In other words, the adolescent brain is designed for adolescence. The report examines the neurobiological and social behavioral science of adolescent development and outlines how this knowledge can be applied to institutions and systems to 1, promote adolescent well-being, resilience, and development, and 2, rectify structural barriers and inequalities in opportunity and access. The report makes recommendations for the health, education, child welfare, and justice system, and aim at increasing opportunities to optimize adolescent development and improve equity. The healthcare system recommendations from the report are to 1, strengthen the financing of healthcare services, including insurance coverage. 2, improve access to comprehensive, integrated, coordinated health services. 3, increase access to behavioral health services. 4, increase the number of adolescent providers, improve their training and their distribution. And 5, improve federal and state data collection on adolescent health and well-being, and conduct adolescent-specific health services research. I often say that the U.S. healthcare system was created by adults for adults. And when we try to feed young people into that system and it doesn't work, we blame them. And we call them non-compliant and hard to reach. When indeed, what is hard to reach are the services, the way they are designed. The healthcare system is very siloed. And this is not how young people think. And young people do not have the life experience to know through which door they need to get through to get those services that they need. For example, a teenager with abdominal pain could be due to stress, gastrointestinal condition, or a pelvic condition. But the young person wouldn't know whether to go through the mental health, the medical, or the GYN door. The Mount Sinai Adolescent Health Center, which is a program that I run in New York City, was established in 1968. The way we work is that we learn from young people. We ask them, what are potential barriers that will keep you from coming for services? What are potential facilitators that will make it easier for you to come for services? And based on what we learn from them, we create a system that works for them with a single door to help them thrive and heal. We have a biopsychosocial, cultural, and spiritual approach to the work. We have 35,000 young people ages 20 to 26 in our care and serve more than 12,000 every year. We provide high quality, comprehensive, coordinated, and integrated medical, sexual and reproductive health, dental, optical, health education, and behavioral and mental health. I often say from head to toes, from mental to dental. We also provide legal services and educational support. We cater to poor youth without health insurance because we know they have limited access to care. But we see everyone who shows up because we feel and believe that young people have the right to get their needs met. 70% of our patients do not have health insurance. All those services are provided to them at no cost. We pay for their labs, we pay for their medication, and we give them Metro cards for transportation. Services are very flexible, and we love if they make appointments where they can just walk in, even if they don't know us at all. We also provide those services confidentially. We provide all the different services under one roof with a single door to enter. And in addition to the big center that we have in Manhattan, we also have school-based health centers inside 6 high school buildings, and through those we serve 24 high schools and middle schools. Now I would like to talk a little bit about the COVID-19 and the impact. It has had a very negative impact on our patients. And we administered a survey of young people, and 400 of them responded. And this is what they are reporting. 33% said that they lost a loved one. 65% reported that a member of their household had either lost their job or were working fewer hours than usual. 35% reported food insecurity, and 21 needed to go to churches and food pantry to get food, and 4% reported losing their home. 65% said that they felt more stressed and much more anxious since the pandemic, and 37% were found to be clinically depressed. 41% reported recent use of marijuana, with 22% reporting daily use. And they also reported an increase of 51% in tobacco use and 41% in marijuana use. And they also reported increased interpersonal violence. The resulting trauma from this pandemic will be long-lasting, and we all need to make sure that we address them. And then lastly, my last point is that we need to ensure equity. There are many sources of inequities in adolescence, including disparities in the social determinants of health, including family and neighborhood resources. Another one is the structural racism, bias, and discrimination. And a third one is the history of trauma. However, inequities can be diminished or eliminated by policies, programs, and behaviors that aim to address disparities. Resilience and equity are pivotal in adolescent well-being. Addressing inequities is essential to achieving well-being for all adolescents. And the Mount Sinai Adolescent Health Center's work is based on positive youth development, social justice, diversity, equity, inclusion, and belonging. And I'm going to stop here.
Well, thank you very much, Angela. And we're going to go now to Renee McConey.
Hi, good afternoon. I am the Managing Director of Health Services at the Door in New York City. And as Charlie mentioned, since 1972, the Door has served the most vulnerable youth of New York City. The Door's mission is to empower young people to reach their full potential by providing comprehensive youth development services in a diverse and caring environment. The Door as an agency serves around 11,000 adolescents and young adults every year, and they range in age from 12 to 24 years of age. All Door services are free. They're completely confidential and provided under one roof. As an agency, the Door offers a wide range of comprehensive services to meet the needs of young people from across the city. We take a holistic approach by offering wraparound services that include healthcare services that I'll speak to in a few minutes, behavioral health services, crisis intervention and assistance, legal services, immigration services, career development and job training, education services, including GED classes and college prep, drop-in services for homeless youth, supportive housing, including two off-site locations, sports and recreational activities, arts programming, including dance, music, and visual arts, nutritious meals every day, and if that's not enough, there's a charter high school in the building serving a few hundred students. And there's no other organization that we know of that provides such a wide range of services all under one roof in one place. Specifically, the Doors Adolescent Health Center is New York City's only federally qualified health center that's embedded in a youth development organization. Around 40% of the 11,000 young people that visit the health center each year, they come to us, they come to the Door mainly for health center services. And to paint a picture outside of COVID, the health center is part of a 6-story building. We take up an entire floor of 15,000 square feet. We have 10 exam rooms, numerous private offices and spaces for counseling sessions and health education. And we take pride in knowing that our health center is youth friendly, it's bright, it's inviting, and it's comfortable for teenagers and young adults. Our comprehensive health services include services regardless of their ability to pay and regardless of insurance or Medicaid, include primary care, sexual and reproductive health care, mental health services, eye care, including eyeglasses, dental, dermatology, vaccines, nutrition counseling, health education, and outreach. We have a peer education program that I'll speak to. We do care management and referrals, and we also do Medicaid and insurance enrollment. We have an on-site medication dispensary and a lab on-site as well. The Adolescent Health Center, our main aim and our focus is to provide access. You know, that's the thing that we lead with. We want to make sure these kids can get in for high quality client-centered care. They deserve to have the same level of service as someone with private insurance who's going to a doctor in Midtown. We focus on being client-centered, and we make sure that we're in tune with the diverse clientele that we see in the health center. Most of our young people identify as female. We have around 20% that identify as male. 90% of our young people are 100% or below the federal poverty level. We serve a growing LGBTQ youth population, young people that are transitioning in and out of foster care, homeless youth, immigrant youth, and most of the young people that we serve are young people of color. 60% are Black and 40% are Latinx. It's important because of that, because of the diversity of the young people that we serve, that we have to have a diverse team. We should be representative of the young people that we serve. We start from the very beginning, from the recruitment, that we make sure that we look for providers and staff that have some experience with adolescent health and have some experience with youth development. And again, we recruit for team members that are representative of the population that we serve. We look for a very diverse team of providers and staff. Another part of what we do to make sure that we're meeting the needs of the young people that we serve is we build partnerships with the community. We do have the luxury of being part of a larger youth development organization, and we do make every effort in the health center to partner with the other programs, such as for immigration services, we do their USCIS exams, so young people get in their green card application. We do sports physicals for the young people at the high school, and we do vaccines and work physicals for other young people that are seeking employment. We also partner with other organizations. This came in handy during this whole pandemic. All of those partnerships that we had, it really helped us out when we had to close the building, and that we were able to lean on other organizations, other healthcare organizations, other FQHCs. And we partner with community-based organizations that are serving similar populations. So when it's time to make those referrals, we can, and when they need to refer to us, they can. I mean, we do a lot in the building, but it's impossible to do everything. We can't do it all, so we have to make sure that those partnerships are in place. I do want to highlight our peer education program. This is a big part of reaching young people. So we have a peer education program of young folks that are 18 to 21 years of age, and they're leaders, growing leaders in the community. They're part of our team, and they're the outward-facing group that meets with young people. They do peer education sessions when the building was open. Now they transitioned to Zoom sessions with young people. They're doing health education workshops and activities that are fun and educational, medically accurate, and best practice. And we also let them sit at the table. We ask them to sit at the table. They're part of our decision making. We reach out to them when we're looking at adding new services, or even to say what services should we offer. And we make every effort to meet the young people where they are. And that step comes in with scheduling. When we were open in the building, we are open, but on a limited basis. We take walk-ins, we squeeze them in. If someone shows up in the health center or calls us, that's the time that they're available. So we make sure that we try to meet their needs right then. And a big part of how we meet young people where they are is communicating in the way that they want to communicate. Am I talking too much? I hear somebody saying something. Okay. They communicate with their phones. So how do we meet them where they are with their phones? We have to expand the technology as much as possible. We've added kiosks to our waiting room. We've expanded the patient portal so they can reach us 24 hours a day. We send them health education campaigns and promotions through the patient portal. We have online appointments. We send reminder text messages that we know they'll see. We even do our surveys through an electronic survey tool. And we use social media as much as possible to reach young people. And again, we include peer educators in the creation of some of those posts and some of the information that's going out. I do want to speak to the pandemic, and I know I'm talking a lot, but I'll try to get through this. But the pandemic really hit home for us. We were open on Friday, and over the weekend, Friday, I can't remember, I think it was the 13th, March 13th, and we had to quickly close for March 16th. We had to very quickly transition to telehealth services. So how do we do that? We deployed laptops, hotspots, and cell phones to providers and staff. And how did we make sure that the patients were able to reach us? We had support staff and some of the health educators reach out to patients directly. Not our peer educators, but we have a team of health educators who called each patient that was scheduled that week and for the rest of the month and walked them through how their telehealth visit was going to take place. And we even had the nursing staff call the patients who were coming up for any follow-up visits, such as refills and vaccines and retesting. We had to get very creative, and we mailed medication and birth control, HIV test kits and pregnancy test kits, eyeglasses, whatever needed to get out to young people, we mailed it. We followed the same hours of operation to avoid any confusion. And we maximized the text line and the patient portal as much as possible to reach those kids. And we used our website and social media as much as possible to communicate with them and also to communicate with the community so they knew what was happening from day to day. We continue to do some of these practices now all the way in July going into August. And we're still reaching out to some of these kids this way. We also had to lean heavily on some of those partnerships during this transformation. We did some things that other agencies couldn't do, and then we had to lean on them for stuff that we couldn't do. And so those partnerships really came in handy. And again, we did our best to get out into the community. We joined every coalition, work group, and committee that we could possibly join. Statewide organizations, advocacy organizations, and everything, so we can stay on top of what was happening with the pandemic. And then on top of all of that, we had to deal with all of the added trauma with our young people involved in seeing all the images and possibly experiencing all the police brutality, institutional racism and bias. And we made sure that young people had access to all the extra emotional support they needed during that time. And again, overall, the priority is always to lead with access and making sure that our young people had access to the services that they need. And we had to get very creative. We had to stay very optimistic that it could get done. We used the technology and every line of communication that we could to transform into what is now a new normal, and it's still an ongoing work in progress. And I'll stop there. Thank you.
Well, thank you very much, Renee. And I will say that you answered one of the questions that was asked, which is around the fact that adolescents use social media probably far more naturally and often than the provider community, and how can the provider community build in that, because I think you spoke to that. But we have another question, we really want to pose it to all three of you around how do we grow more programs and services like the Door and Mount Sinai Medical Center, not necessarily Adolescent Center, not necessarily doing everything they're doing, but moving more in that direction of providing really health services where you start from where the adolescents are and you engage them. And how do we move to build that out And what particularly do we have to look at in terms of the way we finance that? And I think and some of Peggy's remarks on the critical importance of Medicaid.
If I could just comment, I think that you've got two examples of brilliant adolescent health care presented today that are really nationally recognized. I have to say that I think the school-based health centers across the country have been doing really special work in terms of thinking about how to reach adolescents in a more teen-friendly way and with more of a sense of a whole person. And but I don't know if Angela or Renee would want to comment. I'm certainly they're asked this question every day, probably.
Yes. So for the door, we're constantly making sure that our portfolio is diversified. So we do look for grant funding, foundational funding, and Medicaid reimbursement. Young people don't always carry their Medicaid cards or their insurance cards. So, we do have a team that helps young people with that and helps young people get enrolled in Medicaid so we can get the reimbursement that I feel we strongly deserve for the services that we're offering. We don't charge young people, so we do have to depend on those sources. And to reach young people, going back to Charlie's question, it helps the partnership, to create those partnerships with organizations that are serving similar populations. So other youth groups, other youth health center, adolescent health centers, schools, the high schools, and even some of the colleges.
So this is Angela. I think that a good place to start is by talking with young people and asking them, what are their needs, what are things that are facing. That's how we do it. What are barriers, what are going to help you get in, and then you don't have to start big. Like, the Mount Sinai Adolescent Health Center has been around since 1968. The door has been around since 1972. I actually used to go and help the door to see patients. At one point, they could, just to help with the care, and it's a wonderful organization. And you can start very small. The Mount Sinai Adolescent Health Center that is huge, as you heard. We began a doctor half-time, and she was a pediatrician that was an expert in hematology oncology. She was not even general pediatrician or a adolescent medicine physician, but she had a passion. She wanted to help youth, and a social worker full-time. And the two of them started. I think the most important thing is to learn from the young people what is it that they need, and to have a philosophy, commitment, and passion to want to do something about it. And then you start small. And for those people who are interested, actually the Mount Sinai Adolescent Health Center, we produce a blueprint of what we do, how we do it. And if anyone is interested, you can let me know. And I'm always more than willing to talk with anyone. I really believe that the more of us doing this work, the better.
Well, thank you very much. And I really do want to thank all three of the commentators. And I think that they gave you a wonderful perspective. And as I said before, they have been making good trouble for decades, and it has really shown. I do think that we're closing now. We had to start a little bit late. And I think it behooves us all to think about what do we need to do to build back a better, smarter, and fairer health system for youth. And I think a lot of the answers can be found from the people who are on the ground and are experts and the youth themselves. I want to just close with one final slide. One of my favorite U.S. Congress people is Ayanna Pressley. And in her office is the sign that people closest to the pain should be closest to the power. And clearly the disability movement has led in taking on the slogan, "Nothing about us without us," and that's been also adapted by parent organizations, foster youth leadership groups, and other parent allies, and many others. And I think it is really at the heart of what we're talking about. We're successful in working with adolescents when we work with them, not just to them or at them. And we really do have that responsibility to respond, to ensure that people who are closest to the pain or the most disadvantaged have access to the power they need. Representative Ayanna Pressley has alopecia, and that picture of her is as she is, without hair, and with a youth who is also a person with alopecia. And I think that picture just really is what we hope to be about as we work for child health care transformation, working with practitioners, with advocates, with members of Congress, and so on, to enable our child health care systems and our adolescent health care systems really to take on that transformation process of being holistic, preventive, developmental, ecological, and really committed to inclusion, empowerment, and rectifying inequities. And with that, I wanted to say this concludes this webinar. We're going to do a concluding webinar in September, which is really going to talk about how we can put this all together around advocacy and policy transformation. And I would encourage you to go to our website if you want more information, and we will shortly have up both these slides and the recording from this presentation. But again, I want to thank the commentators in particular, and the organizations who really are our national resource partners, which help put this together. So thank you very much.
Thank you.
Thank you.
Thank you for having us.